All right, good morning, everyone. Um, we're going to get started in just 1 minute, so we'll get everyone settled down. Okay, welcome to day 2 of our Shame in Medicine conference. Really nice to see everyone back here. I know some people are still on their way in, and I'm sorry about the rain. We're getting like all experiences of Exeter weather. But I'm really happy to see everyone back. And our first speaker today is Diane Aubin, who has come all the way from Canada, which is really wonderful. And I've known about Diane's work for many years, since the start of this iteration of the Shame in Medicine project. She wrote an interesting PhD thesis, which I read many years ago, about shame in different healthcare professionals' experiences following error. And I'm excited to hear this talk about the work she's been doing more recently around healing after error on both sides of patients and clinicians. So it's very relevant topic I think many of you will be interested in. So Diane, if you'd like to come up, and Diane's going to present for about 20 minutes, and then I'll open it for questions. Here they are.
Good morning, everyone. Thank you for being here so bright and early. Well, not so bright, but early. So yes, I'm speaking today about healing together from shame after a medical error. As Luna was saying, it's about healing together means patients and our families and the healthcare worker. So I'll explain a little bit more as we go. And yeah, they warned me. Yeah, keep pushing. We practiced this morning. Technical support, please. I want to say good morning to everyone online as well. So just an overview, what do I mean by medical error? Because there are a lot of different ways to interpret what medical error means. And so I just want to tell you what I'm talking about when I talk about medical error. The impact of the errors on healthcare workers. This is probably very familiar to you, but we're going to just breeze through that. And yes, the overview and the impact on patients, and then I'm going to talk a little bit about a program we're trying to implement, and after that the challenges in putting that through, and then finally I'm going to leave you with a lingering question that we hopefully can discuss as we go along. And so medical error, you've heard adverse event, patient safety incident. There's many terms for medical error. A lot of clinicians don't like medical error, so they call it an adverse event because, well, that's less shameful, I guess. But essentially, it's an event in healthcare which results in unintended harm. So I'm talking about, there are medical errors that don't cause harm. They call them near misses. And but the ones I'm talking about are the ones that cause unintended harm to the patient, and it's related to the care or services provided, not to the patient. Not to the patient's, not due to the patient's underlying condition. So that's pretty broad, and I'll keep going as we go. Please come on in. Okay, I'll try this again. There we go. So I'm going to start with a story, and the story is about Mrs. Drucker. Now, this is just what I imagine Mrs. Drucker looks like. And I'm going to play you a little video clip of a TED Talk by Brian Goldman, who is an ER emergency physician in Canada. And he also hosts a radio show called White Coat Black Art. And so he's fairly well known in Canada. And he was a great mentor to me when I was working on my PhD. So we worked together a little bit on that. So the first clip just sets the scene, what happened. And he's just a fairly new physician. And he's talking about when Mrs. Drucker came to the emergency.
I saw Mrs. Drucker, and she was breathless, and when I listened to her, she was making a wheezy sound, and when I listened to her chest with a stethoscope, I could hear crackly sounds on both sides that told me that she was in congestive heart failure. This is a condition in which the heart fails, and instead of being able to pump all the blood forward, some of the blood backs up into the lungs fill up with blood, and that's why you have shortness of breath. And that wasn't a difficult diagnosis to make. I made it, and I set to work treating her. I gave her aspirin, I gave her medications to relieve the strain on her heart, I gave her medications that we call diuretics, water pills, to get her to pee out the excess fluid. And over the course of the next hour and a half or two, she started to feel better. And I felt really good. And that's when I made my first mistake. I sent her home. Actually, I made two more mistakes. I sent her home without speaking to my attending. I didn't pick up the phone and do what I was supposed to do, which is to call my attending.
So that's setting the scene. The next clip is when he talks about the consequences of his medical error. Now he's speaking a few years ago, and he's speaking about when he was quite new to the field, to the profession. And I do find, whenever I interview people, clinicians, healthcare workers, they often talk about mistakes that happen when they were young and didn't know any better. So this is the same for Brian. And here we go.
Do you remember that patient you sent home? The other nurse asked matter-of-factly. Well, she's back, in just that tone of voice. Well, she was back all right. She was back in near death. About an hour after she had arrived home, after I'd sent her home, she collapsed. And her family called 911, and the paramedics brought her back to the emergency department, where she had a blood pressure of 50, which is in severe shock. And she was barely breathing, and she was blue. And the emerge staff pulled out all the stops. They gave her medications to raise her blood pressure. They put her on a ventilator. And, you know, I was shocked and shaken to the core. And I went through this roller coaster, because after they stabilized her, she went to the intensive care unit, and I hoped against hope that she would recover. And over the next 2 or 3 days, it was clear that she was never going to wake up. She had irreversible brain damage. And the family gathered, and over the course of the next 8 or 9 days, they resigned themselves to what was happening. At about the 9-day mark, they let her go. Mrs. Drucker, a wife, a mother, and a grandmother. They say you never forget the names of those who die, and that was my first time to be acquainted with that. Over the next few weeks, I beat myself up. And I experienced for the first time the unhealthy shame that exists in our culture of medicine, where I felt alone, isolated, not feeling the healthy kind of shame that you feel, because you can't talk about it with your colleagues. You know, that healthy kind when you betray a secret that a best friend made you promise never to reveal, and you get busted, and then your best friend confronts you, and you have terrible discussions, but at the end of it all, that sick feeling guides you, and you say, you know, I'll never make that mistake again, and you make amends, and you never make that mistake again. That's the kind of shame that is a teacher. The unhealthy shame I'm talking about is the one that makes you so sick inside. It's the one that says, not that what you did was bad, but that you were bad.
There you go. You can see he's still emotional, quite emotional, speaking about this many, many years later. And you can understand why he was interested in the emotion of shame and medical errors. So, this is part of the work I did for my PhD many moons ago. Well, not that long ago, but long enough. Just this, again, is probably fairly familiar to you, but I'm going to emphasize why healthcare workers might be prone to shame. You look at the external environment. I was talking to somebody yesterday. You make a mistake when you're an administrator, you know, you make a mistake when you work in an office. It's not as critical as mistakes that you make when you're in healthcare. They could be life or death. They could cause serious harm. Care is more and more complex. Mistakes are inevitable, and you can argue with me later over coffee or online. To me, there's some people say that all mistakes should be preventable, and even in Canada, there was a report that came out. The recommendation was by 20 25, well, that's this year, we're going to, there would be no mistakes. That's just not possible. They're not all preventable. Expectations are high of healthcare workers. There's still a culture of blame and a culture of silence. And on the other hand, you have the internal pressures. Now, Sandy's going to talk a little bit more about perfectionism, so I won't get into that. Your standards obviously are tied to your high standards are tied to your identity. So it's not only me as a physician, it's me when things go wrong. And obviously harm is the antithesis of the aim. First, do no harm. I'm here to care for you. I'm going to take care of you. And that presumption of control, and you hear it a little bit in the way Dr. Goldman set the scene and said, she came in, it was an easy diagnosis, I knew what I was doing and I sent her home. So that's that presumption that I'm in control, I know what I'm doing. And then of course, hindsight bias. So now I'm going to switch to the other side of things. And this is Vance Wood Davis. His mom, good friends with his mom, Donna. And this is a little bit of her story. When her son died, he was in a single motor vehicle accident. He was 19 and he left. He walked away from the accident and he got to an abandoned house trailer and they found him 36 hours later. He went to the ICU and to the ward and back to the ICU. The challenge for her was that they had stereotyped him as a drunk driver, 19-year-old coming back from work, drunk driver. And she feels for that reason they didn't pay attention to some of the things she was trying to tell them. She knew something was desperately wrong. She was a nurse as well. So here's Donna.
When Vance crashed due to intracranial pressure and subsequent brain herniation, there was a huge wall of silence. The staff didn't come near us. In this busy place, we were all alone. And then 6 years later, when we had our first conversation with the hospital, I asked that the nursing staff who cared for Vance be there. I needed to see them. I needed to see that it mattered what had happened to him. So I contacted one of the staff members to find out if she knew that there was going to be a meeting and would she like to attend. She did not know that there was going to be a meeting, but she said she would love to attend. She told me, I've thought of your son for days, weeks, months, and years. I needed to see you. And unfortunately, this was denied by the risk manager. And I feel this is a great disservice to the staff who wanted this meeting, who wanted to attend. And I think the organization thought they were protecting the workers, but they didn't need to protect them from us.
Well, Donna, what would it have meant for you to be able to speak to some of the healthcare workers?
It would have meant the world to us. As I said, we needed to see that what happened to Vance mattered to them. We wanted to see that they could see how devastating it was to the family. And I know it was devastating to a young nurse who I heard quit the profession following Vance's patient safety incident. I wanted to be able to tell her that we did not blame her. We knew that her and the other care providers did not go to work and intend for this harm to happen. We knew that. I wanted to tell her that I knew she would be the best nurse ever because she would learn from Vance's incident and she would be very diligent with her patients and they would benefit from that. We would all benefit from such a diligent nurse. I wanted to reassure her, not reprimand her. I think we could have given each other support because no one wanted this to happen. Yes, we experienced everything that Wendy and her family did, as so many families do. And on top of that, the guilt that I felt and my husband felt was overwhelming. I felt guilt because I didn't push harder for a repeat CT scan, which I'd asked for several times. Guilt that I was more concerned about being that difficult relative than pushing the nurses to make sure that they were hearing my concerns and acting on them. And then the guilt that my husband and I felt when we had to decide if we were going to pursue suing to get answers. And, and also possibly risk losing everything. As his mom, I was supposed to protect him. As his parents, we were supposed to fight for him, for what happened to him, no matter what the cost. Most of all, we wondered if the staff felt bad and were hurting like we were. Could we comfort each other? Since I suspect they were hurting like we were. I think my conversation with the nurse who wanted to go to the meeting showed that, and the young nurse that quit the profession, it shows it too.
So I don't know if you hear the emotion she still has at the end of that. I've asked her, it must be hard to keep retelling the story. She says, oh no, it's much better to tell the story than to stay quiet. So this is how she's dealing with her grief. So the patient and family on the one hand, Donna talks about guilt. I'll leave it up to you to decide whether she's feeling guilt or shame, but she certainly felt that she hadn't done enough. Grief, anger, they distrust the healthcare system, they might be bitter, betrayed, they feel betrayed and resentful. Some patients even get hostile. But as you heard from Donna, she wasn't necessarily hostile. She understood that they didn't intend harm. And then on the healthcare worker side, you're feeling guilt, shame, distress, anxious, depressed, fear to losing their job. If anybody finds out about this, I'm going to be fired. Fear of litigation, Mick talked about that yesterday, and avoidance. So avoiding people, avoiding thinking about it, avoiding conflict, avoiding the patient. So, this is fairly rudimentary image, but the idea here is that these two parties are pulled apart by this emotional trauma that they're both going through, and they can't reach each other because of this psychological unsafe culture. And what Donna is talking about, where she wasn't allowed to meet with the nurse. Even 6 years later, the nurse wasn't allowed to be at that meeting. So what I'm hoping is that you hear that empathy that Donna has, you hear that empathy that Dr. Goldman had for each other. Is that a way to bridge the gap? That actually unknown, they don't know that about each other. The physician, nurse, pharmacist may not know that the patient has empathy towards them. They assume they're going to be angry and bitter. And on the other hand, patients do. Patients have empathy, and obviously professional healthcare workers have empathy as well. So I'm hoping with this mutual empathy that we create that safe culture. And that's where the mutual healing program is. And I've just got 3 or 4 minutes, and I'm hoping to finish on time for my next speaker. The mutual healing program, I've been working with a group called Patients for Patient Safety Canada. And they have a group all over the world, Patients for Patient Safety. And we've been working on the last 4 years or so on this mutual healing program. And what it is bringing the two parties together to have sincere, genuine conversations about their experience. Sorry about the people in the room over here because I have to look at my slides, but I'm including you. So we have to have, so it's bringing them together to have those sincere. It's not about the facts. So we're not talking about disclosure and incident analysis. We're talking about the experience. So we're not there to talk together about what went wrong, who's to blame, how to fix this. It's really, what did you go through? I'm so sorry. So it's an opportunity to heal. And how we put it together was that, and what we're saying you need for this kind of a program, you definitely need that top-down supportive leadership. Leadership really needs to be on board to create that psychologically safe environment. Willing participants, so it's a volunteer exercise. Participants also have to feel the value in this. They have to feel that this is going to help them heal. So if they go there, just, oh yeah, sure, I'll do it, but it's not for me. They really have to feel that it's something they want to do. And for healthcare workers, a lot of you may or may not have heard about system errors. A lot of the time, most of the time, 90% of the time, medical harm is because of a system error. Things go wrong throughout the process, throughout the care of the patient. It's not necessarily one person that you can point the finger at. But healthcare workers still feel that sense of responsibility. They still, if a patient in their care dies because of an error, even if it wasn't them, they still feel, oh, there's something I could have done, should have done. So I think in order to want to have this kind of conversation, you have to feel a sense of responsibility. Happy to hear otherwise. The other thing is that because of the possibility of conflict that is very emotionally charged, we feel that there should be a facilitator for this conversation and someone who is skilled in conflict resolution, or like a social worker or somebody who really knows how to handle this kind of conversation. And there should be some kind of orientation, like a conversation beforehand, to make sure both parties understand what this is about, what you're trying to accomplish, what the objectives are. So patients feel they've been heard. They know the harm to the patient. As a result of this, we hope that they know the harm to the patient had a meaningful impact on the healthcare worker. You heard Donna say, I just needed to know that this meant something. And you hear that again and again and again from patients. So it hopefully helps them heal. For healthcare workers, it's their opportunity to genuinely apologize. So often in disclosure, it's, well, we regret that this happened to your family and we are mitigating the risk of this happening. So in disclosure, especially, well, in Canada, there are laws that say you can't use an apology in court, but there's still a reticence about apologizing and putting the blame on yourself. So, but this is an opportunity. It's not formal. It's just an opportunity to say, I'm really so sorry about what happened. They get a better understanding, and hopefully it helps them heal. So we've been trying to implement this as a pilot study, and 2 minutes, but the healthcare culture continues to be psychologically unsafe for healthcare workers and patients and families. Like you heard Donna say, she didn't want to be that difficult family. And there's that sense that, well, I don't want to stir the pot too much. And they're also fairly distrustful of the healthcare system once there's been an error. And what we're finding is the hospitals or healthcare organizations that we approach, they're really keen, and a lot of this is great, it's a great value, let's go. They get their leadership support. But then when it comes right down to implementing it, they worry, what is the liability? Even though we've got a lot of legal backing for this kind of thing. And some even say, we really want to protect our staff, and we're worried this will further traumatize them. And patients are also worried that it'll further traumatize patients. Of course, lack of resources. So this is, should I wrap it up? Because I've got another little story. Okay. Wrap it up? Yeah. Yeah, so Joshua's story was just about a father who lost his son and ended up meeting with the midwife, and he only got halfway through of what he wanted to say to her, and she just started crying, and they hugged. And so there is these anecdotal stories of what could happen. So there's no evidence-based situations where this happened, but you hear stories about this kind of thing. So this is my lingering question. Is this a conversation that can only happen organically? Like I say, anecdotally, this happens organically in the right circumstances or by happenstance? Or is it realistic to think that they can be formalized and manufactured or programmed? So that's it. Thank you. Did you want questions now? Yeah.
Yes, let's do questions now. Thank you very much. So I've got Stephen looking at the chat online. So if anyone in the online room has a question, just please type it in the chat. And then, yes, Andrew.
Oh, ever reliable.
Thank you, Diane. Yes, Andrew from King's College, yes. Actually, I train in neonatology, so I totally understand stories like Joshua's story. So the thing is, saying sorry has always been difficult. And I think in the Western world, is particularly hard. Where the culture I came from is much easier. That's right. I mean, things have changed in the 25 years since I left that culture. But you said that there are steps made to actually to say that saying sorry would not be admissible in court. How's the progress of that? And do you have any data to show that you're only piloting a program, isn't it? My second
That's
question.
right.
So that means you have no data yet. So I
On
couldn't
whether
ask
it works,
whether it works
yeah.
or not. Yeah, because that'll be the next thing you'll be doing. Yeah, so saying sorry is so difficult. And I think that's a good start. But will the law change? I don't know whether it might change in Canada, but it won't change here. I doubt it will change here.
Yes, thank you. Alan, thank you for that point, that in some cultures, saying sorry might be not as difficult as others. It is difficult. It's difficult to take responsibility for what you've done. And also, legally, what you call, it should be privileged information that you have in this kind of a conversation shouldn't be able to be used in court. And we do have laws in every province and territory to say that if you say you're sorry about a medical error, this cannot be used in the court of law. So there are what we call bylaws, and this has been tested in court, and so far there has never been a case where this kind of apology has been used against a clinician or a practitioner. Did that answer your question? Yeah. Yes.
I think.
Oh, sorry.
Do we have an online?
Yes, we
question?
do,
Sorry.
from Marie. It's the mutual healing programme sounds great, but how does one reassure the hospital healthcare worker that litigation will not be pursued after? As more details are revealed during the session, it could be healing, but it can also bring up more anger.
Good, very good question. I guess it depends on the country, how the hospital would have to seek. This is where it gets complicated, right? The hospital would have to seek legal counsel if they're worried. In Canada, we have the Canadian Medical Protective Association, who is backing this program for us. So they said if physician, if they call and say, I'm supposed to do this, is it okay? They will say, yes, here are the risks, but we support this. So getting backing legally and reassurance, I guess, from the organization's lawyer. What was the second part of the question?
So yeah, as more details are revealed during the
Yes,
session,
yeah.
it could be healing, but can also bring up more anger.
Yeah, and that's the details. I don't know if you mean the facts about the case, what went wrong. This is where the facilitator would lead this conversation away from what went wrong to, yes, we know, we're looking into this, we're looking at this, the incident, we're analyzing it, but today what we're talking about is how you felt, and the apologizing. It's not about the facts. So that's, but really good question. This.
Hello, my name's Tina. I'm a nurse and a development coach. I'm here in the Exeter area. In my career, I've participated in lots of conversations like this, Diane, and they've always been incredibly powerful. I think that creating the formal space for this is really important. And the thing that I'm mindful of, and I wonder what you think, is people who find it really difficult to have a voice. So it works really well for the articulate, but if you are somebody who, maybe needs an interpreter, or you struggle to say your words, or your condition means it's hard to be in a room with other people, I think you need almost that pre-level of facilitation. And I just wondered if any of that's coming out in what you're exploring.
Yeah, that's good. Yeah, we often think, oh yeah, everyone can advocate for themselves, but not always. And the pre-work would be the facilitator sitting down with the patient or family and saying, this is what it's about, preparing for what it's going to be like. The other thing is, often in disclosure, you have the patient and family, maybe 2 or 3 people, and then the social worker, the CEO, the physician responsible, the patient care manager, the director, and so on. And you have this plethora of care workers and the family who feel very isolated. So this is more of a one-on-one, or bring an advocate. A patient could bring an interpreter, that's a great idea, or an advocate, somebody who can speak for them. And on the other hand, if the clinician really feels they need someone there to advocate to help them through this, but not a big group, not, yeah.
Okay, I think we'll take 2 more questions. There's one online and then one.
Yep, so the online question is, how can a healing help the patient seek justice from the medical error? So that's...
Yeah, and that's an important question too. I think these are 2 separate things in my mind, is seeking justice, litigation. If the patient feels that they want to go through litigation, this is probably not, that's a conflict situation. I'm looking at you as if you asked the question. But so we don't suggest that this conversation happens if litigation has started. If it's finished and the patient family do want to still meet, then that's quite acceptable. Healing, the idea, and there is evidence out there to say that a lot of patients really don't want to litigate. They really don't, but that's the only, like Donna said, that's the only way she could get an answer. So meeting and having a full disclosure and taking care of the patient often prevents, or it keeps the family from litigating. But they have their full right to litigate if they feel that's what they are owed.
Hello. Well, thank you very much for that presentation. Most interesting.
Thank you.
This has always been a subject close to my heart. I'm a retired NHS GP. The incident that you have brought to mind to me this morning, I think, is more of a tale from about a very, very junior doctor. When I was 25 years old, my second job following qualification, so this was 1974, I was doing my first 6 months of the medical job rather than the surgical job. We had an elderly man came into the hospital with severe back pain, but there were some features about it that made it look as though he should have, had to be ruling out meningitis. So it fell to me under the supervision of a registrar who was the next grade above me, and this wasn't his specialty. He normally was a pediatric registrar. This shows how, things have always been, actually. He was covering, okay. Anyway, I did my very first lumbar puncture under his supervision, and the CSF that came out looked purulent. So it looked as though he did have meningitis. My registrar immediately called for a dose of intrathecal penicillin to inject straight into the CSF, which was standard procedure at that time. And I'd done the lumbar puncture, was very pleased with myself, injected the medication. It was only later on that evening when the patient started convulsing that we thought something's going on. It could have been the condition that we were trying to treat. However, the registrar had realised that he'd told me he'd asked for, and I had administered a massive overdose of penicillin intrathecally. And the man didn't regain consciousness during his time that I was around. He was taken to intensive care. Intensive care wasn't, in 1974, wasn't what it is now. However, so we obviously spoke to my consultant. It was clearly the registrar who was taking most of this responsibility, but imagine how I felt. I had actually administered a potentially lethal dose. The following day, yeah, the consultant wasn't there. I didn't see him that evening, I'm pretty sure, but we certainly had a good discussion the next day. There may be a subject of a discussion about the fact that he wasn't there that evening, but and he insisted that he was going to tell absolute truth to the family, exactly what had happened. And both me and my registrar colleague were quite apprehensive, probably. I mean, I was much less experienced than he was, and thought, oh, we're really going to be for the high jump here. But he was insistent that he's going to come absolutely clean about everything, because we knew we'd made a mistake, and it could lead to severe consequences. That job lasted 6 months. We never heard anything about medico-legal procedures during that 6 months, but obviously I was still under the same medical defence organisation that I'd originally joined. I never heard any more about that case, never heard any more. And I don't know what happened, because I moved away to a different area. But having reflected on that over the years, I thought what my consultant did, which we were so aghast about at the time, was so much the right thing to do. Yeah. He'd spoken directly to the family. Yeah. He'd told them the truth. Yeah. And throughout my career as a GP, I've realised, I've not studied this, but anecdotally, if you tell people the truth, they know that we're all human, that mistakes can occur even in the best system. That's usually the best policy. Sorry I've taken so long to ask a non-question, but I think it's something that certainly affected me for the rest of my career.
What a story. Thank you for sharing. Thank you very much.
Thank you, and I think it really demonstrates just the impact these kinds of experiences can have for a lifetime. So thank you very much, Diane, if you join me again. So I'm very happy to say our next speaker is Sandy Miles, who is, I think this will follow on really nicely. She's going to speak to us about perfectionism in medicine. And Sandy is a GP who works quite locally in Brixham. She's also a GP and GP trainer, and has done research around shame in professional identity formation. So I welcome you to the podium. So if you can speak for about 20 minutes, and then I'll facilitate some questions.
Thank you, Luna. Hello, everybody, and hello, everybody online. Perfectionism. Interestingly, the word perfectionist came from a group of religious people in the 17th century. So it's moral perfection is where that term perfectionist comes from. Not really often what we think about when we think about perfectionism. And really the root of it is that belief that your whole self-worth is based on your achievements. This is a really powerful message within medicine. Within medicine, what you're rewarded for is what you know and what you do. We're much less good at accepting you for who you are, the humanity around medicine. And through my career as an educator and as a GP, seeing the damage that perfectionism can do is why I'm talking to you today. There is, within our broader society, a real culture of perfectionism, and it's growing. This is not just about medicine. Thomas Curran is a psychologist, and he's done a really interesting and very accessible book about perfectionism and really the growth in large part because of the different forms of media we now have access to that make people very aware that they're never quite good enough. There are myths about perfectionism, and Thomas Curran provides a lot of really good data to smash some of them. That perfectionism is what leads to success, and the data does not support that. Success is obviously something that you can define in lots of different ways. The other one, I think, is this feeling that being a perfectionist is just who you are. That is your personality, it's your traits, it's unalterable. And again, the evidence does not bear that out. When I was doing my research in shame and professional identity formation, I had the pleasure of talking with Richard Jones, who is a very tall man, who he's the clinical director at what's now called Practitioner Health, which is a health service that was set up for providing care for doctors and initially for GPs, actually in the UK, who had mental illness and addiction problems. It's now expanded and it's available to all doctors and medical students in the UK. And when I was talking to him about the demographic over the 10 years it had been running at that point of his patients, of his clients that came to this service, he says it's really shifted. When they started out, it was mainly 50-year-old, mainly men, and alcohol addiction was the prevailing challenge. Now, most of the patients they have are young women, and they come with anxiety. And their anxiety is about making a mistake. And interestingly, he says, in his experience talking to people about that the anxiety about making the mistake is not actually about the patient harm. It's about the exposure. It's about being in front of the GMC. It's about being on the front page of the Daily Mail. But he recognized that the cluster of anxiety that people are experiencing, and that's what people will describe, actually the emotion that underpins all of that is shame, that they're not good enough. And this often occurs for doctors in his experience who haven't actually made a mistake. They haven't actually been exposed in any way, but the fear, the anticipatory shame that they feel is what makes them mentally unwell. And going back there, in the psychology literature, there are these terms, and I'm just going to go through this with you. Adaptive perfectionism was Hammercheck's term. It's now kind of been called positive perfectionism as a sort of more recent update. And this is what I call looking up perfectionism. This is about goal setting. This is saying, I've got this maybe quite challenging, I'm going to set myself this quite challenging goal. I'm going to work my way up towards it. I know I'm going to have setbacks. And I know that from the beginning. I accept that, but it's not going to stop me. And in this case, people can, you can recognize it, because if there is a setback, they'll get over it. And importantly, when they get to the top of whatever hill they're climbing, they'll celebrate that achievement. They may share that with other people. They'll feel comfortable with that. And at the bottom there, I've said that's linked to guilt. And what I mean by that is if there is a setback, those people will feel guilty. But they don't, on the whole, in the theory, feel shame. The opposite is maladaptive perfectionism. And I call this looking down perfectionism, because the driver for this type of behavior is working incredibly hard to avoid falling into that pool of shame that's lying on the floor. That dark pit which represents all your greatest fears. And this, for a lot of people, doesn't look like perfectionism. This looks like people who might avoid work. They might avoid stepping out, challenging themselves. They may procrastinate. They may need a lot of reassurance. And many people wouldn't label them as perfectionists. But it is that fear of failure that's driving those behaviors. Some people call it covert perfectionism. And it's deeply, deeply linked to shame. And again, these are the risk factors for perfectionism in the psychology literature. The block there on neurodiversity is it's an emergent area of research and of exploration, and the current kind of ideas around that are maybe people with neurodiversity feel a sense of outsiderness, is that a word? Outsiderness, and so they feel they have to work harder just to gain their place in society. So that may be driving what looks like a perfectionist trait. And there are been identified these different types of perfectionism. So there's self-oriented, which is, I want to be perfect because it's important for me. There's other-oriented, which is, I want everybody else to be perfect. And I'm very intolerant if other people's perfection is not good enough. And then there's the socially prescribed perfectionism, that sense of, I've got to be good enough for Instagram. I've got to be good enough to meet other people's expectations of me. And it's the bottom two that are really growing in incidence and prevalence within our society and within medicine. So it is a female-dominated picture in terms of prevalence. Sorry, that should say percentages. But it's a high prevalence. It's actually, I think there's a kind of a myth that perfectionism is much higher in medicine than in other, say, student bodies. And the research doesn't bear that out. Actually, art students have the highest rate of perfectionism by the kind of psychological measures. And within that medical culture, though, there are particular groups who are vulnerable. And given that now 70% of our medical student intake are women, this is a lot. When I say immigrants there, I'm using that term in terms of anybody who is migrating to a new venue. So it might not be from another country, but it would be from a new site. So anybody who feels new to an environment, by my definition here, is an immigrant. And that phase of transition is the point at which you risk harm from this perfectionism because you're so desperate to get it right. I work with international medical graduates here in the UK doing communication support with them. And when they talk to me about the stories that have affected them, they're often happening in that first month that they've arrived. They've been bullied, they've been laughed at, something has gone wrong. They're very, very vulnerable in that space. But there is no evidence of any difference across specialty. And I think, again, there are myths within medicine that, if you're a perfectionist, then you have to be an anaesthetist or whatever. But actually, perfectionists exist in all medical specialties. And this is, I think, just a nice illustration of what it feels like. And I'll just let you take a moment to have a read of that. It's not a lot of fun. And people who have adaptive perfectionism, even those people who, succeed by whatever measure that is, they reach their goals, the evidence is they suffer a lot of mental distress. So actually suicidal ideation is really common, even in those people that we would label as having adaptive perfectionism. And my take on that is because you become so focused on your goal, you're not able to connect maybe to other parts of your life that you need to support your humanity. And these are the quite devastating, often, effects of perfectionism on clinicians and on patients. There can be delays. If you've got a perfectionist in an emergency situation, and they're weighing up the options and they're terrified of making a mistake, that could be catastrophic. Equally, if you're dealing in the environment that I work in primary care, you may over-investigate. You may cause inadvertent patient harm or excessive resource use by over-investigating. And the risk of having a very narrow focus is you don't see the whole picture of the patient and their setting. And importantly, you don't learn from mistakes. So what helps? Setting realistic goals, enjoying the process. I'll come back to that. The tyranny of should, this is Karen Horney, who's a psychoanalyst term. For me, the word shame is all about the sh. It's about the silence. It's about the should. And every time I hear that word being spoken, shame is there somewhere. Breaking up tasks, objective feedback. I train a lot of GP trainers, and the trying to give people objective feedback is a real skill you have to learn. It doesn't come naturally to us, but it makes a huge difference when you're giving somebody a feedback on their actions rather than who they are or their personality. This is my friendly Yeti. This comes from the work by Carol Dweck on the growth mindset. She was an educational psychologist working with primary school children who gave them a task that was way beyond their working level. And she noticed that half or a portion of the children went, oh, I can't do that. We haven't studied that yet. And the other children went, oh, I don't know, but I'll have a go. And she labeled those children as having a growth mindset, this idea that we're not a fixed entity, we can always develop. And this phrase, moving from proving ability to improving ability, is one of the terms that came out of that. And I use this Yeti as my yet reminder. So any feedback you ever give anybody is, well, you didn't do that, or you can't do that yet. Completely changes the premise by which they can then develop and grow. There are treatments for perfectionism, and they work. So Richard Jones, within the practitioner health, they generally use CBT. The first task they give people is you have to write an email to a colleague with a deliberate spelling mistake in it. I'm not going to say who's a perfectionist in this room, but I'm just... And they ramp it up. They've kind of got a scale of 10, and they just keep ramping it up till people realize the world doesn't fall apart. It's okay. Kristen Neff, the queen of self-compassion, and I think her quote here I found so true of my experience of talking with people in this area. Everybody feels that you need that self-criticism, otherwise you wouldn't get up in the morning. And again, there's no truth in that, but it's a story we tell ourselves. So I love stories, and we've heard some wonderful stories from Diane today. And I'm just going to share a story with you. This is about a lady who had to collect her water from the well. And she had 2 pots with which she went back and forth, day after day, week after week, month after month. And one pot was perfect, and one pot had a crack in it. And because of the crack, it meant when she got back, that pot was only half full rather, and so she had to repeat the journey every day. And the pot felt terrible, felt really bad about this. And eventually, she said, please get rid of me. I'm causing you so much extra work. It's terrible. And the lady smiled and she said, well, do you know when I bought you, I realized there was a crack in the side. I thought, well, that's not a problem. And you haven't noticed this because you've had your head down and you've been worrying all this time. But actually, what I did was I sowed seeds down the side of the path, and the water from your pot has watered those seeds and given me beautiful flowers for my house, which bring me great joy. And the king of songwriting, forget your perfect offering. There's a crack in everything, and that is how the light gets in. Thank you very much.
Any questions, comments? Barry?
Thanks, Andy. I spend a lot of time with medical students, and I think that we prime medical students for at least a perception that perfectionism is something that should be aimed for. So, we should be engaged in a preventative program, I suppose, rather than managing it when it becomes obvious.
Yeah.
Do you have any suggestions about how we might do that?
So I feel like the tactic I've employed unconsciously, but it seems to be where I'm at the moment, is I ask them who is the perfect doctor. Have they met them yet? Because I haven't met them yet, and I would struggle to define who they are. And so if you're saying you're striving for perfection, or you're striving, then surely you should be able to delineate what that looks like. And it's interesting when people talk about perfection in medicine, they often use a surgical analogy. They often say, well, you've got to do the perfect cut and you've got to sew it up beautifully and not make any mistakes. And I'm like, well, that is only one part of surgery. You've got to talk to the patient before and after. You've got to communicate with your team. You've got to be up to date with your research. To narrow down the practice of medicine to an ability to make a tidy cut and do some nice stitching seems really wrong. Medicine is much messier than that. It's much more complex than that. And there's no way, in my mind, you can be a perfect doctor. It's too complex. And that may be overwhelming for them when you first really put that to them, because they're suddenly like, wow, yeah, I don't even know now where I'm headed. But in a way, it can take away, I think, that sense of, okay, there's something I have to be. And I think the other risk we run is we run the risk that we are setting people up to be a perfect doctor. And really, they've got to be the doctor that they're going to be, using their individual particular talents to further patient care. So removing that idea that there is an ideal is something I think we could do a lot more work with very early on.
Yeah, so there's a comment which perhaps you can respond to, Sandy. So this is from Becca. Perfectionism and capitalism seem to be perfect, in inverted commas, bedfellows. It feeds into scarcity and lack in ways that are materially tangible rather than spiritual. However, so she goes on to say, however, the economic element that feeds into our structural systems of shame seems less commented on.
Yes, but I think in the work that was presented at the beginning yesterday shows that those systems really exist within medicine, and give that kind of cultish air to medicine, that belonging to a tribe, and wanting above all things to stay within that tribe and never do anything that will result in you being ejected from it. And so perfectionism gets bound up in that idea, I think, in people's heads that they have to be perfect or there's a risk they're going to be thrown out of it. Yeah. Thank you, Becca. Interesting.
Yeah, I'm Brinda Naik. I'm actually a biomedical scientist from background, but I teach undergraduate medical students. And as what I'm going to say is something related to the online question, where you have presented. I learned a lot about perfectionism. Thank you very much. That was really helpful.
Thank you.
I think you have portrayed it as an attribute that I have. Rather than how society makes you to have that. For example, you said that immigrants and women tend to have this perfectionism. It comes from the fact that sometimes people didn't believe in us.
Yeah.
People didn't trust us with those kind of attributes. A woman, maybe if she's in surgery, she still struggles with competing with that men whom she has to prove herself. Similarly, ethnic minority, I work a lot with ethnic minority students, and I've created kind of many projects and interventions to support them. In one of my recent projects, I was talking to a Black student who is here in Exeter for the last 3 or 4 years. And she said that the first day she arrived in the halls, she met a white student who looked at her and said, "Oh, you're here because of contextual offer." And that kind of thing, on the first day when she arrived at Exeter, that's the first thing she heard in the halls. That makes her feel that I have to always compete and prove myself. So even though it's her attribute, it comes from the society. I think that kind of angle would be very helpful here to help out those kind of students who really struggle with that concept.
Yeah, thank you so much. That's really raises such important points. And as I said, it's very clear to me people are most vulnerable when they first arrive in a place. And yeah, I've heard some awful stories of what people have been told, and it's not a level playing field, and people do feel they have to prove themselves, and in many cases they do. It's not a myth, that is a reality. And yeah, that is something the rest of the group have to address rather than that individual, I would argue. Yeah, thank you.
Really interesting. Sandy, thank you.
Hi.
For the rest of the group, I support doctors in many different ways, GPs, and Sandy knows that. My comment is something where perfectionism leads to a breakdown in communication. So I know doctors who don't support each other because they don't feel perfect enough. So there's no peer support, and they feel embarrassed in front of each other. They can't ask. And with the increasing number, let's say with female doctors, I think they're even more isolated amongst themselves. They're unable to support each other. They've got many competing things in their lives, and they withdraw rather than engaging. So that contextually, I'd love a way to understand, encourage them to communicate more with each other, to support each other, because that's been my experience, how perfection pervades their communication.
So that almost makes it sound like it's an infectious disease that they're scared of catching, like there's somebody's made a mistake, and if they engage with them, they might be in some way infected by that process. Is that what you're saying?
Yes, there's a shame disease, because they don't know what they feel they should know. And they could ask a colleague, how should I look at the patient's history or do the diagnosis, but they don't talk to the colleague about it.
No.
Because, if you like, in communication terms, I mean, shame could be a disease just from that.
Yeah. And I think, again, that's not something that necessarily individuals can wrestle with. I think that requires the culture within the environment. I currently work in a practice that I bless the stars I've landed in, which is where the culture of that practice is very much geared to, we talk about everything. Everybody talks about everything at all levels, and that is led from the top. It's not something that's happened by accident. It's a very constructed environment to create that atmosphere, and it changes everything. So I think there's a real risk of ladling it onto individuals, that responsibility to be that way, but you do have to have that safety in the organisation that you're working in to be able to engage with people and support them properly. Excellent leadership in our practice.
Another comment online, so I'll let Stephen read it out.
Yeah, so this is from Emma, who says that yes, she agrees. It's difficult to say publicly that we accept error in medicine/patient safety, given the implications, so it creates a false perception/expectation.
Yeah, and that, I think that's always been true, but I think your lovely story from long ago explains how actually if you create that environment where people do just say sorry, apologise, talk about it, then the fear is much diminished. And I don't have data to support that, but I imagine there's probably fewer errors in those environments if people feel safer to talk about it. Sorry, Steve, we keep looking at you when you're not online. Sorry, online people.
Okay.
Hi, I'm Andrea. I'm a child adolescent psychiatrist. That quote that you put about the root of perfectionism is believing your self-worth is based on your achievements by the psychotherapist. Just thinking about that in the context of recruitment. So I haven't been involved in medical student recruitment for a long time. I haven't interviewed medical students for a long time, but I remember the process for me, and then I compared it when I was a registrar, and it's moved on, and it's incredibly challenging. And I just think if the cohort is high percentage of females. We're seeing a pandemic of adolescent poor mental health in females of under 18-year-olds. And, I think about the kind of morbidity we're seeing in mental health of medical students. And I guess where I'm wondering what you think about recruitment and whether actually we really need to be changing recruitment, because recruitment is setting up teenagers to aim for something that is so hard. They're obviously going to be neurotic. They're obviously going to have psychological vulnerabilities that mean that they can't cope with uncertainty, that they can't cope with failure. And so it's almost like we're starting, kind of way too early in terms of affecting them for the rest of their career, and also driving recruitment to mean that people that are less vulnerable to some of this are not going to be applying to medicine because they're just not going to be interested in seeking that achievement goal, which you describe. I find it quite worrying that it is kind of more women, and they're the young people that I'm seeing, essentially, some of them.
Yeah. I mean, I'm not worried about the women. It's going to be fine. But I hear your concern, and it's obviously out there. We're all very aware of it. I think the answer probably lies in there's a couple of things really. One is recognizing, if you have to stick to your recruitment being based on a grade at school because that's the only way you can narrow the pool down, then you have to address that early on. That first week that people are in medical school, you need to be talking to them about the fact that just high grades are really not the answer to being an excellent doctor. And you need some very senior people to be giving that message. Otherwise, yeah. Well, they've looked at that. Yeah.
It's not going to affect your admission, but after you've been offered a place,
Yeah.
you can have an opportunity to think about these are your benefits of practice.
Yeah, they've done some studies on it in Germany looked at potential medical students as to who had adaptive perfection and what they call maladaptive perfection. Actually, the ones who didn't get in had a much higher rate of maladaptive perfectionism. So within their system, that was being kind of filtered out, if you like. But I think, interestingly, there's been a shift in the UK medical school system now that when you graduate, you're just allocated a number by lottery in terms of where you go next. And what that's doing is basically saying, well, if you've graduated medical school, that's enough. How well you did at medical school is now irrelevant, and you're all equal. And talking to medical students, what's the impact of that on those who are currently at medical school? And they kind of say, well, actually, what we do now is we collaborate. We talk to each other because we're not in competition with each other anymore. So there may be small steps, there may be things like that, systemic changes you have to make. I'm not sure you're going to change the individuals. You need to change the environment that we're expecting them to train in.
I know several people have their hand up, but if you're in the room, I suggest you speak to Sandy after. But one more comment from Anna, which is going to be brief, I'm sure.
Yeah.
Hi, Anna.
So I was wondering, kind of following on from that, within medical school, do we set students up to become even more of a perfectionist by the way that we teach and assess students, in that there's always a right answer, when actually when they get into medical practice, we all know that there's not that right answer. Yeah. And I know I personally felt, if I just learnt more, if I studied more, then this feeling of like uncertainty and not being good enough would go away, whereas it's impossible to always find a right answer, because there often isn't one in medicine.
Yeah, there's no comfort blanket that like a practice set of MCQ questions is there to just rattle through. I think exploring early on that humanity about how messy medicine is. They're kind of sold a lie that you just look at people's biochemistry and alter that and it's all fixed. So yes, I think engaging with the human side of medicine very early, and supporting, as I said before, who they are, not just what they know and what they do. They need to be valued as individuals, and valued members of the profession, really. And it's a long piece of work, but it has to happen, because AI is going to do most of that stuff anyway, she says. Controversially put that out there. There we are. Thanks, Anna.
Thanks so much, Sandy. All right, we'll take a short break. We'll start at 10 past, so we'll have 25 minutes for the break. So we'll start slightly later, Mary.
think what we might do is just abandon this altogether.
Oh yeah?
I mean, otherwise I won't be seen. You know? Well,
Do you
actually,
have, do you need, I think you're okay, but do you have something you need to read off or anything like that?
I mean, can I be seen? Should I just... I don't know. It's actually not as high as I thought. If I can put the mic down.
We just need you mic'd, that's the thing. We need you to speak into these, so
Yes.
the online people can hear.
Yes. Oh,
It's pretty steady and everything, so you know it's safe. That's the most important thing. I could very easily
this is that quest for perfectionism, so that you want to you will make other mistakes instead. So how are you getting on? And do you have a career path in mind?
So I'm doing a teaching job this year, and then I was doing like doing reflective oncology, set something about like 8 to days.
Honestly, when I was a student, oncology was active, or at least pretty much. And chemotherapy was horrendous. Radiotherapy was pretty horrendous. And yet in more recent years, it's very interesting to be
and I think the reaction when I say oncology to a lot of people is, oh, that's so horrible, that's so depressing, but actually that's really not my experience of that. There's so much you can do, there's so much new innovation there. And when it is there's still so much good work we can do where that's some of the most valuable things.
I was very much into palliative care for the GP. My practice and my wife actually trained as a palliative care, well, no, she trained as a psychotherapist. She was most interested in palliative care, so she worked in the hospital. And again, people say the same thing.
I really enjoy looking after patients because sometimes do some of your best work, I think, sometimes because you're looking after the psychological family, that you feel like sometimes you're not doing in your day-to-day practice because you're in the constraints of the NHS, you've got 10 minutes appointment with GP, some things that you would love to do but you can't. I'm not very good at being outside.
Radiotherapy department is in the basement. Dark corridors down there. And just
Did you work in Devon?
No, I've never worked in Devon. I've worked in all sorts of places.
You're not from Devon?
No, I'm not, but I live here now. I live in Sydney, which is why I'm here. Really. So you trained here, did you?
I trained in Cardiff and then moved down
Should we start back? Yeah, the what? I was never trained to be a teacher. Right. I'll introduce you.
Yes,
Is that-
yes. Did you see the big one she gave me initially?
My wife is 4'10",
Okay.
so whenever she goes anywhere, she hates these. She says she absolutely hate them because. Yeah.
I must start doing that actually. But sometimes I just use a mic and I just wander. But then if I have a mic and this, and I'm trying to keep an eye on it.
Yeah, I know.
So I would suggest a very big mic.
Yeah. Okay, let's start this session. Thank you. So this session is on clinical shame, and our first presentation is by Dr. Mary Doherty on Autistic Psychiatrists, Silenced by Shame, an interpretive phenomenological analysis of the reasons for non-disclosure and avoiding formal diagnosis. Thank you.
Thank you. Oh, sorry, excuse me. These slightly out of the way. Is that okay in terms of the mic? Yeah, lovely. Okay, thank you. Right. Thank you so much for the opportunity to talk about this project. It's very dear to my heart, but it's been really, really difficult. And to just share this with you and know that you'll get it is just so valuable. The artwork is by James Henderson, who's the deputy lead for Autistic Doctors International, which is an organisation that I founded a few years ago. And the idea is just to know, it's about positionality and the importance, particularly for any of you who are supporting students or colleagues, the importance of positionality, just knowing for yourself whether you see the world through that neurodivergent lens or not. It's worth just thinking about as I talk through. So this project is part of my PhD, which I recently completed, and it was focusing on autistic psychiatrists. We also had another project on the wider membership of Autistic Doctors International, which I'll tell you just a little bit about by way of background. And there's two parts to the psychiatry project. One is the part that I've already published on, and then the second part is the diagnosis, disclosure and shame, which is what I really want to talk about mostly today. In terms of all the work that I do, it's around improving healthcare for autistic people, both as healthcare providers and as patients in the healthcare system. And really, we know we've had very little training, on autism, but the goal is just for all healthcare providers to become not just autism aware, but autism competent. But on a wider sense, for autistic kids to grow up confidently autistic, for us to move from that core deficit paradigm, which is the traditional framing, and move to a neurodiversity affirmative approach. That's the overall goal. But today we're just talking really about, how we can address the shame that is experienced by autistic psychiatrists. A few myths and misconceptions around autism. We don't have time to get into it in detail, but, first of all, that we can't be doctors. Nonsense. There's loads of us. Think of your colleagues. The other one is that we don't have empathy. And again, that's complete nonsense as well. The reality is that many of us experience hyper empathy. And I have to be honest and say that my own experience of hyper empathy has been, one of the reasons why this project has been so difficult on a personal level. I mean, I've had thoughts of giving this talk, and there's been, it has occurred, I could just stand here and cry and say this is how hard it has been, and you would understand that, you would know that. But it's been incredibly painful on so many levels. The last 9 months have been hideous. And it's different because most of you are researching shame. You're looking for it. I wasn't at all. So I was very surprised by the data. Anyway, back to Autistic Doctors International. That's our website. This is the leadership team. I started that group 2019 with less than 10 members. Because I knew I wasn't the only one. We now have 1,200 members spread right across the world in every continent, including Antarctica, and that's the leadership team. This is the psychiatry leadership team. They're probably the most active group, and I'm delighted that Anna is here with us today, waving there in the corner. A little bit about our membership. We published a survey a couple of years ago on the membership, and just think about the specialty groups. What do you think are the most likely, the biggest specialty group in ADI, and then second? It's not what you might think. GPs are the biggest group numerically, and then psychiatrists second. But then think about the relative numbers of GPs and psychiatrists. The question is, are the psychiatrists the most overrepresented group amongst our membership? And that's been consistent since the beginning. We thought it was an anomaly at first, but no, it's not. Most people have not disclosed. This was the wider membership, less than a third had disclosed. And remember, most autistic doctors don't know that they're autistic yet. We have data showing that, 90% of autistic adults over 50 don't know that they're autistic. And that's going to be the case for doctors as well. So lots of people don't realize. But of the ones who do, most people don't disclose. And just think about how that feels. That's James's, drawing about what it feels like to be masking, to be working your entire professional life, presenting as something other than, who we really are, and just how that feels. And we know that masking is associated for autistic people with poor mental health, including suicidality. And when we looked at the mental health outcomes for our own members, the suicidality is just, way higher than for other medical groups, way higher than the general population rate. 3/4 of our members having experienced suicidal ideation, 1/4 having had a previous suicide attempt. And really interestingly, those who viewed autism as a disorder, which was a minority of the group, but that group had an association with a previous suicide attempt. So it's all about this, how we view ourselves, how we feel about ourselves, and the importance of that. So anyway, this is the paper that I published initially. So it was the first part of the project was looking at autistic psychiatrists, and it was how they recognize themselves and others as autistic. This paper was very well received. It was the next phase that was a bit more tricky. I'll come on to that. The methodology was interpretive phenomenological analysis. I won't go into it in detail, but it's particularly useful for insider researchers. And in terms of the psychiatry project, I classify myself as an almost insider researcher. I'm not a psychiatrist. I've co-authored chapters in psychiatry textbooks. I've written in the psychiatry literature. I've worked in psychiatry as a junior doctor. I've experienced psychiatry as a patient, as a loved one, as a relative. But I'm not a psychiatrist, so almost insider researcher. The participants were recruited from ADI, the subgroup, the psychiatry subgroup of ADI, Autistic Doctors International. 8 participants, all based in the UK, all senior successful psychiatrists, 6 consultants, 2 associate specialists, spread across a range of subspecialty areas. 1 had a childhood diagnosis, 2 were diagnosed in adulthood, and 5 self-identified as autistic in adulthood. Won't go through the demographics. We've blurred it a little bit to, make broad categories and not just to avoid any possibility of, triangulation or, identifying who the participants might be. We've been very careful to do that. But the themes, there were 3 themes. The first one was how people came to recognize themselves as autistic. For several, it was similar to myself, recognizing after a child was diagnosed. Others had recognized maybe during medical school lectures or encountering an autistic patient, maybe supporting an autistic junior colleague who was clearly autistic, and then having to acknowledge the similarities. Some were recognized by their patients. You're one of us, aren't you? And the thing is, we do recognize it. Anyway, I won't go down. But it's important because, as one quote, we don't recognize ourselves from training. If we don't recognize ourselves as autistic, how on earth can we diagnose the patients accurately? And that's really important, as I'll come to in a minute. But then once the once the respondents said that they recognized themselves as autistic, they started to realize that loads of their colleagues were autistic, particularly in neurodevelopmental psychiatry. Lots of reasons why that might be, but yeah, I mean, if you think about it, it makes a lot of sense. But they also recognized that before, like once they knew they were autistic, they could recognize autistic patients very easily and quickly, build rapport with autistic patients very easily, but they recognized that before they knew, they missed autistic patients all the time. As one said, my benchmark for normal is me. And you can see how it happens. You know, patient comes to a clinician going, I think I'm autistic, gives a fairly standard list of autistic features. And the clinician goes, sounds just like me. I'm not autistic, therefore you're not autistic. You know, and that's happening all the time, still, currently. Do you know, so that's why, again, positionality really matters. So then when I published that paper, it actually got quite a lot of positive, response. I love this one, you know, this take on it, you know, and what might be the medical equivalent of a plot twist. You know? Love that. Even the American Psychiatric Association, they put out a daily alert about this. Like, they've really taken this on board. They're really supportive. But then what I noticed was, because I'd be fairly active online, people who would follow my work, people who would often engage with me, weren't engaging in the way that they normally would. And I was kind of going, oh, what's going on here? Like, people were retweeting, reposting, but they weren't commenting, or they were messaging me privately. I was getting emails. And I was going, what's going on, you know? Now, at the time, I was then in the second part of the analysis, which was looking at the reasons for formal diagnosis, for avoiding or seeking a formal diagnosis, and also the reasons why people didn't disclose, because none of them were out at, none of them had disclosed. And it was all to do with negative attitudes of colleagues, fear of consequences, you know, not being believed. You know, you're autistic, don't be ridiculous, of course you're not. Or the corollary to that was being believed and then losing credibility amongst colleagues, you know. The diagnostic criteria is a barrier because they are, what are they but a list of how you have failed to be neurotypical, you know. And for successful senior psychiatrists, it's hard to see yourself within that, you know. The stigma, stereotypes, myths, you know, fear of judgment, no role models, lots of different, and they're all very, very valid. But what I realized when I went back to look at the data was that it was more than that, you know, and I was kind of going, what on earth is going on? And then I realized it was shame. And as I say, like the shame bomb dropped. I saw it, and it was like, oh my God, how had I missed it? Because this was a reanalysis in preparation to write up the data. And I had previously analysed the data 2 years prior and just didn't see it, you know? And then suddenly, once you know, put on those shame goggles, it's everywhere. And that's when I contacted Luna, found the project. And the thing is, actually, Sandy had come and given us a talk a couple of years ago, and had suggested that we might, and a fabulous talk, and suggested that, you know, we might, as autistic doctors, maybe write something for the project. And initially we kind of go, good idea. And then we thought about it and I was like, no, we're not touching that. You know, so it's a couple of years later that I'm seeing this and I'm going, oh, what, how do I deal with this? So thank you, Luna, for being so gracious and so helpful in terms of, you know, like, I've been in such a deep rabbit hole of shame. It's been brilliant. I'm absolutely loving it. Absolutely loving it. It's just, it's fascinating, but it's so hard because it's so painful. You know, paralinguistic indications, I had no idea what any of this was, but I went and I looked at all the recordings again, you know, and when I was looking for it, of course, it was there everywhere throughout all of the recordings. I'm going to play a very short clip, which we recreated from one of the interviews with permission from the participant, recreated from the transcript and the recording by 2 neurodivergent actors. And the participant we were in the garden, she was in her garden, because she wanted to avoid being overheard by people in her house, people that she lived with. And she was preparing to talk to me about her experience of being an autistic psychiatrist. For any psychiatrist in the room, if you're thinking, is there psychosis going on here? No, it was just literally the fear of being overheard.
Hold on a second. I think it's, hello, is anyone there? No, I think it's the next door neighbor's dog who huffed. Is anyone there? Is that a naughty dog? No, I think it's animal. It's not a person. I just keep hearing intermittent rustling. Okay.
Just to stop you, if you want to reschedule this to a time that,
No. Okay. It's fine. I just keep hearing weird rustling sound in the undergrowth between our garden and the next garden. I'm actually gonna go slightly more over here at the back of the lawn. Right. It's all going in the transcript, isn't it? The general paranoia and persecution.
Totally understandable.
As a theme, we can put that as a theme.
Yeah, absolutely. The terror of being discovered. Yeah.
Yeah.
Yeah, just that terror, of being overheard, being discovered, being known to be autistic, and that sense of shame as I looked at it and thought, where's it coming from? It's these childhood messages, family, school, peers, social rejection, bullying, and then later on workplace conflicts, and it's such a pervasive theme, I think, for so many of us, that they just, from childhood, from the earliest days, getting the message that we're somehow defective, broken, less than, that neurotypical is the bar that we're expected to reach, and anything less is failure, and recognizing this and the implications for autistic people generally is just been really powerful for myself, and as I think of my own journey in terms of shame, I've been really lucky to walk that path from living with chronic shame, to the point where I couldn't walk past a shop window and get a glimpse of my own reflection without wincing, and having had the opportunity to walk that path where I'm just, confidently who I am, confidently, openly autistic, has been a real challenge. And I'm so glad that I was able to have done that before this turned up, because it makes it easier to deal with. But that's not to say it's not hard even still, So this was a poster on the project that I presented recently at the American Psychiatric Association meeting a couple of weeks ago, actually. A couple of weeks ago. And this is just some of the quotes from the participants about what it felt like to be autistic. I can't be this thing. The sense of if she'd even tried a bit harder to be a bit more normal. Hard child, very odd. Also very able, odd child, and we talked yesterday about intersectionality, and the impact of, cultural factors. And this is one of our participants, who came from South Asian background. My mother, it's a personal insult to her to say that her daughter was just so dysfunctional as a child, what is wrong with her? And it's that pervasive sense of what is wrong with you, And yeah, this was one of the participants who came to realize, having been asked to assess a junior colleague, felt terribly uncomfortable. Yes, he's autistic. What did that say about me? And this one actually was a psychiatrist who realized after viewing a webinar on autistic girls and suicide, and she went to a friend that she had known since she was 5. And the friend was a clinical psychologist at this point, and she asked her, do you think there's any chance, I might be total hypochondriac here, could I possibly be autistic? And the friend goes, has it taken you so long to realize? I thought you knew already, She's like, no. And then what she said was, when she said that, I felt like a bit like, oh gosh, she's known this behind my back and not said anything, and I felt a bit like humiliated. Maybe other people would know. Felt a bit thick being a psychiatrist who's had 7 years of therapy and would diagnose and recognize autism in other people. For me to not realize until 40 is ridiculous. And then the sense of, well, if you're a psychiatrist and you're autistic, then you're probably in the wrong job, There's particularly to do with the sense of us not having empathy, and if you don't have empathy, how can you do your job? That's the assumption by colleagues. It's completely erroneous on so many levels. This one's really hard as a parent, and particularly because my own parenting journey means that's what drives all of the advocacy work that I do, and this one is hard to see because these were psychiatrists who were neurodiversity affirmative in their approach to themselves and to their patients. But when talking about their own kids, there was still that latent neuronormative expectation, almost that sense of pride in a child who was able to mask and make friends, reluctantly coming to the acceptance, you know, that they didn't want friends, you know. And then that last one, it breaks my heart. It was about a 10-year-old kid, you know, do you think she might be autistic? No, I haven't seen anything. She seems quite all right. Ugh. It's really hard because as a parent, I get that, you know. It's so difficult. This one was somebody who had recognized that she was, this was before she recognized she was autistic. She had gone to a mother and baby group and met a mother who disclosed that she was autistic. And what she said was, I remember thinking, how can this person be a mother if they're autistic? How are they going to get their child's state of mind? Is this actually emotionally safe for this person to be a mother? And what she said was, if I was thinking that as a doctor with a training in psychiatry, there's no way other psychiatrists are not going to think that about me. You know, and that was one of the reasons that she didn't feel able to disclose. Another one had presented to her local specialist autism team. She presented at their multidisciplinary team. And first of all, she said that they were very surprised that any autistic doctors existed. Now, this is the local specialist autism team. You know, keep that in mind. They wondered if I had really had a proper diagnosis. What she said was, when she presented the patient, it was deeply unpleasant being watched for signs of autism. I've experienced that as well. It was so bad that as soon as I finished, couldn't stop crying for about 20 minutes. And it's still tearing me up now, even, you know, and she showed that emotion in the interview. You know, I've never felt like that before. Just that sense of being watched and seen, knowing that the assumption is that that is, you know, being seen as less than. You know, so as I try and work out what to do with all of this and how to progress with it, it's really, really difficult because, as we know, it's so painful. And the shame that I feel, even though I don't have that, I no longer have that sense of shame myself about being who I am and being, you know, autistic, I still, seeing my colleagues who can't acknowledge being autistic, it's like I'm touching their shame, and it's like an affiliative sort of shame. It's really, really hard. You know, and shame avoidance, shame anxiety. I mean, you know, like, it's so difficult to bring this to colleagues, particularly in psychiatry. But I think it's just so important, you know, so important that we do, because of the impact on autistic kids, because so many autistic kids are just growing up with that sense of shame, you know. And again, that antidote to shame being vulnerability. So I try and do that. I try and model it. This is something that I published. I mean, as doctors, you know, publishing in the Lancet, maybe the holy grail of career aspirations, maybe not for maybe one of my most shameful days. This is an account of an autistic meltdown that I had, entirely related to sensory overload. It's published recently in the Lancet, which you might like to have a look at. But our medical students are really leading the way. This is a couple of quotes from a paper that's in progress. You know, the negative associations promoting a sense of shame. It's almost like if you have it, the dirty secret, and you don't let people know. Oh gosh, that I feel that on a visceral level. But then, if you behave as though you're ashamed of something, then you send the message that it's something to be ashamed of. And for other autistic people, it was important for me to not act as though I was ashamed of it. And then the other quote, you know, everyone thinks of me as a weird, odd thing. But just seeing other people like owning it made me want to own it. You know, and where I go from this, I mean, from an ethical perspective, this is really tricky. Challenges, you know, personal challenges, how to navigate the space in psychiatry, because it has been really difficult. Some of you will know, I mean, an invited talk on this topic was cancelled very last minute. Now I've had, I've had an apology from the college. The talk has been, you know, the recorded talk has been distributed, you know, and we're working towards sharing the message, and you know, I'm very glad of that. But it's still really, really tricky, you know. But knowing how important this is to the autistic community means that I have to continue with this. So I will write it up and publish it. Final reflection is from Anna, from a paper that was in, or a piece that was in the Times recently, you know, and the quote, what are we doing to the next generation if all the successful autistic people are in hiding? So I'm really grateful to Anna and colleagues being, you know, openly autistic psychiatrists. And leave it at that. Please do get in touch. Sorry, I went slightly over time.
Thank you so much. Time for some questions. Right, we'll start in work our way back.
Hiya, Mary. Thank you so much. My name's Emma. I'm autistic too, and I've forced myself into a conference situation specifically to come and hear you. And you've over-delivered. So thank you.
Thank you.
So to my question, or it's more of a pondering really. So I work in lived experience workforce development. I'm also a researcher. So I work for the Peer Support Service here at Devon Partnership NHS Trust. And I'm curious about shame and perfectionism when you are recruited specifically for your lived experience, whatever that might be, and you have to wear it on your lanyard every day. Yes. So I just wanted to bring forward a couple of things that I hear from peer colleagues about having to be the most perfect example of recovery, or having been through the justice system, or living with autism, managing it, being functioning, emotional regulation. And I just wonder I think it's probably an unexplored area, what the prevalence of shame and perfectionism is in the lived experience workforce, which is growing, but we need to help it to grow by looking after them as they go.
Absolutely, I completely agree. And a couple of things on that. I think the prevalence of shame in the autistic community is not something that we have looked at all, and we absolutely need to on so many levels. I mean, we talk about stigma so much. We talk about stigma, but we don't talk about how that is embodied, how that is experienced, and that is a shame. And it's like unless we know what we're dealing with, we can't challenge it. But particularly in the lived experience workforce, I absolutely, completely agree. And I've experienced it myself because I've been involved in research, autism research, as a sort of lived experience expert as well. So I've kind of straddled that peer, that lived experience and the professional. And I have seen how colleagues, and this is through, biomedical autism research, I have seen how colleagues in research have viewed my autistic colleagues before they knew that I was autistic too, and how they have struggled to get the notion that I could be autistic and I could be a professional peer as well. And just watching researchers navigate that space, you can see them rearranging their faces. It's really, really difficult. So I would love to work on that. I would love to, because we need to just, we need to talk about it. We need to talk about shame and autism so much and that we haven't. Yeah.
Thank you. We've got a question online.
Yes, a question, comment. Thank you for this great presentation. I'm curious as to what made you do the PhD in this topic on autistic psychiatrists. I'm a very proud autistic psychiatrist with an autistic young adult child. I am neuro-affirming, and have continued to spread the message and share the knowledge that autistic psychiatrists do exist and have a successful career in life.
Yeah, I think, when I started ADI, Autistic Doctors International, I had a sort of a vision that we have this repository of knowledge about autism, and our colleagues just don't understand a lot of the time what it means to be autistic. There's so many myths and misconceptions and all of that. And I just had a sense that we need to be able to share this. We need to be able to share our knowledge. But I also recognized that the only way to really make impact in healthcare is publish in the peer-reviewed literature and in the medical literature rather than even the autism literature. So that's what we targeted. That's what we focused on. And then I got into all of this looking at healthcare for autistic people. And I got into that area of research before I started looking at our own members. And then throughout the journey towards the PhD, which started out intending to be a master's, and then it just it spread, it's so much bigger. I just realized that I could dovetail the two. And, it was all about kind of leveraging our insider perspectives, but we can't do that unless we're out. So that's where that sort of focus on positionality came from. And then, of course, the psychiatrists are the most interesting group. I wish I'd been a psychiatrist. I also wish I'd changed when I first thought about it. But anyway, it is what it is. And I realized that they're the most important group because who writes the diagnostic criteria? Only psychiatrists. And, it's like, look at the gay community. Homosexuality was in the DSM 50 years ago, and a gay psychiatrist standing up and saying, I'm homosexual, I'm a psychiatrist, completely changed the course of history for gay people. So the psychiatrists are doing similar. So that's why they're my most interesting group.
Thank you. We'll go this one.
Hi, Mary. I'm Will from Duke University, and thank you so much. That was just an absolutely
amazing presentation, and I understand why people traveled here to see just you.
Oh, thank you.
Seriously, I get it. You know, I'm a family physician and a clinician, and my understanding of autism is largely abstract. You know, I from medical training and knowing some folks with autism, but my ability to empathize and really understand is somewhat of an abstraction and an effort. Yet when you start talking about shame being autistic, I start to feel something that is recognizable, right? I can start to understand your experience a little bit better on a dimension that I can relate to from my own path to shame. And that I was thinking the whole time, what is it about this topic that could be functional here? Because so often we run away from the topic of shame, but and as I've thought about it, and I'm interested in your comment on this, it's actually possible that it's so deeply humanizing that it might be one of the fundamental ways for us to understand people that are misunderstood and neglected and stigmatized by sharing in some of the emotional experience that we're also just as prone to, maybe for different reasons.
Wow, I'm like, I want to flap at that, because yes, exactly, that's exactly it. And like lots of you will be familiar with the double empathy problem, which is a theory developed by autistic sociologist Damien Milton, and it's the idea that the traditional assumption is that, autistic people don't understand, neurotypical people, and, that if there's a miscommunication, it's the fault of the autistic person. Whereas the reality, when you look at it from the double empathy lens, is that, it's a bi-directional misunderstanding. Non-autistic people have just as much difficulty understanding us as we might the other way around, although we have to work harder at it, so we're actually better at understanding you guys than the other way around. But that is exactly... You're so right. You are so right. I'm so excited. Sorry. Yeah. Yeah. No, it is that shared humanity. And I think that's potentially also a link with parents, because there's a lot of division really in the autism world, often between, adult autistic people and parents of autistic kids. This notion that you're nothing like my child, or, that we are somehow taking resources from, kids with higher support needs, which, there's a big discussion, but there is that sense of, we have so much to offer because we can explain experiences that your child is having, but there's too much tension sometimes for us to be able to communicate and be listened to and listen. But it's that experience of shame, because there's a good literature showing that parents so anything to do with autism and shame is all about parents, and it's about the vicarious shame that parents feel. Let's work together. Yeah.
Do you want to,
Yeah,
probably one more question. This one, and then...
There's just a comment from Emma Wiley. Absolutely, having worked in EDI for a decade, totally agree that shame, stigma have the capacity to unite us all in connection, help us understand each other's differences. Thank you, Emma.
So I know there's loads more questions, so we need to move on to the next one. So please do catch up with Mary afterwards, if that's okay. So let's still say a big thank you. The next presentation will be online.